Hello, welcome to my channel. We know that K-tape was initially used for stabilization purposes until it gained attention in London 2012 Olympic Games, where companies donated a lot of tapes to countries. Although there is a depth of high quality research on this subject, kinesiotape, and elastic tape used by sports medicine clinicians to improve athletic performance and in athletes is said to enable a reduction in the discomfort during physical activity in those with orthopedic problems. Today, I'll be analyzing 3 research papers to determine if kinesiotaping is effective as purported. This is your evidence-based health section with Michael. Stay glued and let's learn together as rehabilitation experts. First research I want to talk about was conducted by Alicia et al. And in this study it was entitled The Effect of Kinesiotaping on Pain in Individuals with Musculoskeletal Injuries. So this was basically a systemic review and also a meta-analysis that was used in this research. Articles were eligible for inclusion if they were categorized as randomized control trials or cohort studies. Due to the limited original research on effect of kinesiotape application, a specific patient population could not be extracted. That is for the inclusion criteria. With the exclusion criteria, basically, the Alicia et al. Used excluded articles that was published in other languages or prior to the year 2003. That means that this research we are talking about is quite current. So all these things were excluded from the study. The research investigating the effect of kinesiotape application on pain, that is post-surgically or in non-musculoskeletal conditions, was also excluded from the study. In order to evaluate the highest level of evidence, any article categorized as below 2 were omitted from this review. We know that research has 5 basic levels in terms of quality. Hence, level 1 has higher quality of evidence, higher quality of randomized control or prospective study, testing for previously developed diagnostic criteria on consecutive patient, sensible cost and alternative, values obtained from many studies with multi-way sensitivity, that is the analysis, and also a systemic review of level 1 randomized control trials and level 1 studies. So this indicates that we have trusted evidence. We can trust this evidence of systematic review. If you agree with me, now let's go on and analyze the result of this study by Alicia et al. So the finding from this systematic review show that pain reduction achieved by kinesiotaping was no different from reduction achieved by many traditional modalities. So kinesiotaping gives more help, including application, ease of application, both time and cost effective, relatively to other physiotherapy modalities like electrical stimulation or cervical manipulation, and in some cases can be applied by patient. Combined results indicated that kinesiotaping may be useful reducing pain in individuals with musculoskeletal injury, although the reduction may not be clinically meaningful. They declared no conflict of interest. That means that we can trust this research. And the second research I want us to talk about is current evidence does not support the use of kinesiotaping in clinical practice. That is the topic. And this was also a systematic review by Pereira et al. So Pereira et al. Asked basic questions, which are, one of the questions that Pereira et al. Asked was, 1, is kinesiotaping more effective than a sham taping or perhaps a placebo? And also compared to no treatment or other treatment in people with musculoskeletal conditions. The second question that Pereira et al. Was trying to address is the addition of kinesiotaping to other interventions more effective than other interventions alone in people with musculoskeletal conditions. So Pereira et al. Decided to categorize these results into certain components. The first one was effect of kinesiotaping versus no treatment. So over here, Pereira et al. Was trying to compare the effect of kinesiotaping versus no treatment. Kinesiotaping, after they realized that kinesiotaping reduced anterior knee pain during stair ascent and descent. However, when you compare the median effect of this margin, it was like 0.5 on a pain scale that is from 0 to 10. Which was quite lower than the threshold of the clinical importance nominated in the study. Despite this, the authors concluded that kinesiotaping might be effective. The quality of evidence for this comparison was rated very low. And guess what? They used a single trial in this study, which means that it has a high risk of bias. The next thing they talked about, the next question they were trying to address was the effect of kinesiotaping versus sham taping. So in this research, the 4 trials involved participants with patellofemoral pain, shoulder pain, weight splash, or low back pain. So the outcome evaluated were pain and disability. These are the 2 basic things that they were looking at. So kinesiotaping was either no more effective than sham taping, or its effect was too small to be considered clinically meaningful by the original authors and the reviewers. All 4 trials were single studies, which means that no 2 studies looked at the same group of patients. The chance of bias was very low in this study, so the grade rating from the quality of evidence was very low. The third question that Pereira et al. Was trying to address was the effect of kinesiotaping versus other interventions. So these studies showed that the effect of kinesiotaping were no greater than the interventions which they compared to. So they compared to interventions such as exercises, thrust manipulation, and so on. And they realized that any benefit was too small to be clinically meaningful as well. 2 trials were single studies with high risk of bias involving participants with different musculoskeletal conditions and with anterior knee pain. So they also tried to, according to Campola et al., showed that kinesiotaping did not have significant greater benefits than the McConnell patella taping. So the last one Pereira et al. Tried to address was effect of kinesiotaping plus other interventions versus interventions alone. So in this study, they evaluated the outcomes. That is, kinesiotaping was no better than other interventions alone for participants with conditions such as rotator cuff lesion and shoulder impingement syndrome, chronic neck pain, patellofemoral syndrome, and patellar fasciitis. So I guess you are developing interest. Now let's progress to review the last paper so that we can conclude this section. And the last paper was a paper that was trying to address certain minor questions. Do you know there is a claim that kinesiotaping improves performance in sports? Now, let's review the evidence to see if this is true. Now, Jennifer et al. Reported on the effectiveness of kinesiology tape on sports performance abilities in athletes. So, this was also a systemic review, and she concluded that there are no significant effects in favor of K-tape when compared to other tapes, that is sham or second intervention. So based on this research, there is no convincing evidence for the effectiveness of any construct within the sports performance abilities. Now let us conclude on this. Although there is no substantial evidence for the use of K-taping, most research cannot discount its benefit. And if you apply it, patients feel good. So you can't discount the benefit. Now let's conclude by a paper from Mustafafi, which is entitled A Systemic Review of the Effectiveness of Kinesiotaping for Musculoskeletal Injury. So over there, he concluded that this systemic review found insignificant evidence to support the use of K-taping following musculoskeletal injury, although perceived benefit cannot be discounted. So as I said, the benefit cannot be discounted, and that is why we still use kinesiotaping. So K-tape, just like other physiotherapy interventions, have neuromodulation effect, providing some sensory feedback from the tape, that is the tape to the brain, perhaps creating the basic concept, it feels good. And this is what we normally hear from our patient. And I want to encourage all of us that we should use the basic evidence and the best available evidence to treat our patient. This is your physical therapist, Michael, and I would want you to enjoy this video. If you think it is beneficial, please share it among your colleagues to also learn and apply the current evidence base. Thank you. See you.